Good evening medicos, myself Dr.Krishneswari and our channel is back. So we were discussing about the symptoms of neurology in the previous sessions, is it not? So I think that till now you are very clear, you are very happy with the sessions. So today we are going to a fresh symptom, that is syncope. As far as syncope is concerned, it is a very important symptom in neurology. So syncope, it is also known as faintness. So what is syncope? What is the definition of syncope? So in this class, in this session, we are going to discuss about the definition of syncope, what is presyncope, and also pathophysiology behind syncope. Okay, so syncope, we will see the definition of syncope. So the syncope is a transient, and what is meant by transient? It lasts for a short period. Transient and sudden loss of consciousness and also loss of postural tone. Okay, so there will be sudden and transient, two terms are there. One is loss of consciousness and second is loss of postural tone. Why there is postural tone and conscious loss? Because there is reduced cerebral blood flow. When the blood perfusion to the brain is reduced, there will be sudden and transient loss of consciousness along with loss of postural tone. So we will be talking about posture and all in the coming sessions. So when here there will be consciousness loss and also postural tone loss due to reduced blood supply. So it is known as syncope. So syncope, it is common in old persons. Okay, so when the person is above 65 years, then there is chance of syncope, and also if the patient is having postural hypotension. Okay, when the patient is presenting with postural hypertension and if the age is above 65 years, there is more chance of syncope, and sometimes this syncope is associated with dizziness also. So you will be well versed with dizziness. So if you are having any doubt, please refer to the part of evaluation of vertigo, the link of which I will be keeping in the description box. Okay, so syncope. The syncope, it is associated with presyncope. Sometimes it is associated with presyncope, sometimes it is not associated with presyncope. Okay, so what is pre? Pre means before. So something the patient will be experiencing before syncope. The experience of the patient before syncope is known as presyncope. Okay, so this presyncope, in presyncope, the patient will feel that he is going to get faint. You understand? So there will be feeling of blackout. So suppose for example, we are standing for assembly. When we are in school, we will be standing for assembly, is it not? For longer time we will be standing in upright position, and suddenly what happens? We will be feeling dimness of vision, we will be feeling increased sweat, we will be feeling feeling of heat all over the body, we will be feeling that we are going to fall, is it not? So this sensation is known as presyncope. That is, before syncope, what the person experience is known as presyncope. You understand? So this presyncope, it may or may not be associated, may or may not be associated with syncope. So this presyncope, it will get corrected. If once the cerebral blood flow is corrected, then this presyncope will be get corrected. It will not go for syncope. You understand? So this is the thing behind syncope and presyncope. So if a person experience something before falling, it is known as presyncope, and if the person falls, it is known as syncope. You understand? Okay, so this is about the definition of syncope and presyncope. Now we are going to discuss about the pathophysiology of syncope, which is very important. If we are understanding the pathophysiology, then it is very easy for us to understand. So basically this syncope, it can be two. One is benign syncope and other is serious form of syncope. Benign and serious syncope. So this benign syncope, that is when there is some change in the vascular, normal cardiac activity will be there, and when there is some change in the vascular tone and heart rate. Okay, then the patient will have a syncope, patient will fall down, then it is benign. It is of not a serious condition. You understand? So it may be revert to normal soon and the patient will not experience anything after this episode of syncope. But in case of serious syncope, it is associated with cardiac arrhythmia. Okay, so when there is change, some serious change in the heart rate, when there is serious change, what happens is the patient may go for syncope, and it is a type of serious syncope. So these are the extremes of syncope. It may be acute, not acute, it may be benign without any serious condition, and it may be associated with serious condition. So syncope is very, very important. Okay, because there are two extremes in syncope. You understand? So next we are going to the pathophysiology of syncope. So basically there are two important pathophysiologies as far as syncope is concerned. So first is when there is defect in venous return. So when there is reduced venous return. Okay, when there is reduced venous return, and second is when there is defect in vasomotor reflex. Vasomotor reflex. Understand? So there are two basic pathophysiologies, very, very important, and which is very, very easy also. Okay. So one is when there is reduced venous return, and second is when there is defect in vasomotor reflex. You understand? So first we will see what happens in reduced venous return. So we all know that humans stand upright, is it not? So we have a straight vertebral column, is it not? The persons who are not having straight vertebral columns are not considered as humans, is it not? Yes. So we are having a straight vertebral column, and so we are standing upright, is it not? So we are living in earth, we all know. So earth is having a specialty. What is that? Gravitational force. So what earth will do? Anything we are putting up, it will attracts towards itself, is it not? It attracts the thing which is putting up, so it will be attracting it towards down. Like that, human beings are upright animals, is it not? So what happens is the blood in the body will be it has a tendency to pool on the lower extremities. You understand? Not only lower extremities, sometimes upper extremities will be looking downwards, is it not? So what happens is there is a tendency of the blood to pool on the pool downwards. So there are some basic mechanisms in our body which helps the blood to go upwards. You understand? So it will not allow the blood to pool in the lower part of the body. So we will see the three basic mechanisms. This is physiology, what I am saying. So we are discussing about pathophysiology, and the three mechanism is, one is pressure reflexes. Pressure reflexes, these are present in the arterioles and venules. So this will not allow the blood to pool downwards. You understand? So pressure reflexes which is present in the arterioles and venules. Second is aortic and carotid reflexes. Aortic and carotid reflexes which is in the heart. So what happens is there will be this aortic and carotid reflexes also, it will not allow the blood to pool downwards. You understand? And third is muscle action of lower extremities. Muscle action of lower extremities. So this muscle, it will be continuously pumping the blood upwards, so that it will not allow the blood to pool in the lower part of the body. So these are the three basic mechanisms which controls or which regulates the pooling of blood. You understand? Which regulates or controls the pooling of blood in the lower part of the body. So pressure reflexes, aortic and carotid reflexes, and also muscle action of lower extremities. You understand? Suppose So usually 3/4 of the venous blood. So what happens is 3/4 of the systemic circulation. 3/4 of systemic circulation is in the venous system. Okay. Systemic circulation is in the venous system. So what happens is when there is reduced venous flow. So when there is reduced venous flow towards heart. When there is reduced venous flow towards heart, what happens is there will be reduced cardiac output. Understand? So 3/4 of the blood is in the venous system, and also when there is reduced venous return, what happens is there will be reduced cardiac output. So what happens? Suddenly this systemic arterioles, normally there will be systemic arterioles which causing vasoconstriction. So when there is vasoconstriction, what happens? More amount of blood will be reaching the heart. So this is the normal mechanism. But what happens if we already discussed about the mechanism which helps in increased venous return, is it not? Which prevents the venous pooling. So what happens is when there is any defect in the venous return. So when there is any defect in the venous return, what happens is the cerebral blood flow is reduced to half. Understand? Cerebral blood flow will be reduced to half and the person will experience syncope. Understand? So this is the first mechanism which causes syncope. So normally 3/4 of the systemic blood is in the venous system. So there should be normal venous return in order to maintain the cardiac output. So when there is reduced venous return, what happens is there will be cardiac output, reduced cardiac output. So what happens is normally systemic arterioles will induce vasoconstriction in order to increase the blood flow to the heart. So when this mechanism fails and when the mechanisms which controls the venous pooling fails, there will be reduction in cerebral blood flow to half and it results in syncope. I think you understand. Okay, this is the first basic mechanism. Very, very easy, no? Mechanism is. The second mechanism is when there is defect in vasomotor reflexes. Vasomotor reflexes. So we will see what are the two vasomotor reflexes. One is coronary sinus stretch reflex. Coronary sinus stretch reflex, and second is coronary depressor reflex. Coronary sinus stretch reflex and second is coronary depressor reflex. So what is coronary sinus stretch reflex? So what is coronary sinus? Coronary sinus are the group of venules which join to form a larger vein. So it is in the heart, is it not? So the veins supplying the heart will be draining to the coronary sinus, is it not? So what happens is when there is stretch of the coronary sinus due to increased volume in the heart. So what happens is it is present in the atria, and so what happens is there will be increased volume. So volume will be when there will be increased volume, what happens is this coronary sinus will get stretched. So what happens is through the vagus nerve, this reflex is carried to medulla oblongata. Okay, through the vagus nerve. This is carried to this stretching due to increased volume is carried to the medulla oblongata. So what happens is the efferent thing from the medulla oblongata, what it causes is it will be decreasing the vagal nerve activity. You understand? So if the afferent fibers will be carrying the reflexes towards the medulla oblongata through the vagus, and the efferent thing from the medulla oblongata will be reducing the vagus nerve tone. So vagus nerve activity. So what happens is vagus nerve activity is gone and sympathetic stimulation will be there. Sympathetic stimulation will be there. So because of we all know that the function of sympathetic stimulation, sympathetic nerve, it increases heart rate. Is it not? It increases heart rate. As a result of that, this volume will be reduced. So sympathetic and parasympathetic nerves I have explained in the previous video. Is it not? So if you are having any doubts, please refer to that. I will be putting the link in our description box, in the description box of this video. Okay. So here this coronary sinus stretch reflex, what happens is there will be increased volume in the atria. So coronary sinus gets stretch. There will be stretch of coronary sinus, and so what happens is this reflex will be carried by the vagus nerve to the medulla oblongata, and from the medulla oblongata the efferent fibers will be acting, and what happens is there will be reduced vagal nerve activity which leads to sympathetic stimulation, that is increased heart rate. You understand? And second is coronary depressor reflex. In coronary depressor reflex, what happens is there will be withdrawal of sympathetic activity. You understand? Sympathetic activity. Here there is what? Stimulation of sympathetic activity, and here there is withdrawal of sympathetic activity. So these are the two basic mechanisms taking place in case of vasomotor reflex. So this is important in controlling the BP. Okay, BP and also heart rate of the person. So when there is defect in this vasomotor reflex also, it leads to what? Reduced blood flow to the heart. In turn results in reduced blood flow to the brain, leading to syncope. You understand? So these are the basic mechanisms behind syncope. So I hope that you understand this. If you are having any doubts, please you can ask me in the comment box. Definitely you will be getting the answer. So today we will be closing this session with the definition and pathophysiology of syncope. In the next section we will be dealing with the types of syncope, which is something complicated. So we will have a fresh session on types of syncope. So hope you understand. So thank you for your support. Happy learning. We will meet again. Thank you so much.